So this is an intimate paper. So I wish to talk about this disease, which is Fabry disease, that is a rare disease, but not that rare, because in Pavia we have a referral center. We have been dealing with this disease for quite a lot of years. First of all, let me begin with a message. So if we think of a lifesaver doctor, we immediately think of an ER doctor or someone else, but we never think of eye doctors as lifesavers, whereas we, in certain cases, are the ones who allow our patients getting a certain diagnosis, and this can really change his or her life expectancy, because the diagnosis is really the basis for the life expectancy. Not only that, but also for the course of the disease. So what is the diagnosis based on? A very simple exam, the slit lamp, and in a very banal way, suspicion, because what we see is not a symptom but a sign, because we do not get patients coming to us because of clinical symptoms, but because of signs, but because this is sometimes an occasional or accidental finding, but in the literature it is written that corneal signs are diagnostic until the opposite is proven. So every time we see a corneal sign, in this case in particular a vortex cornea, we should immediately think, could this be a Fabry disease? And if not, we can go for the differential diagnosis. So, but this sign can really change the patient's life. So the sign is a diagnosis. These are very, how to say, obvious images, the ones that you find in textbooks, but that's not what you actually see in clinical practice. This is just to suggest how a vortex cornea might look like. But so if we suspect Fabry disease, you can see here that there are very mild and blurred signs. We diagnosed a patient where you see that the one eye has no clinical signs, whereas the fellow eye has a very thin vertical line, and that line should make us suspect that there might be Fabry disease. So every time you check a cornea at the slit lamp, you should really pay great attention to all these signs, because they may change the life expectancy. So until the opposite is proven. And what are the chemicals which may actually cause vortex keratopathy? This amiodarone, tamoxifen, hydroxychloroquine. So we have a whole list here on the slide. This picture shows quite clearly the progression of Fabry disease. Consider that the first symptoms set on when the patient is 3-4 years old, but on average the patient is diagnosed in the 30 to 40 decade, and this is due to kidney insufficiency or central nervous system diseases. And there are no clear causes for this, so no hypertension, so on and so forth. So in the literature, there is a very big study, the FOSS study, with more than 1,000 patients recruited. The range is quite variable, between 20 and 80%, but not all the patients recruited have been diagnosed in exactly the same way. So actually, the eye symptoms range from 65 to 85%. All texts repeat that the eye manifestations are very early and pathognomic in nature. So, what is Fabry disease? It's a chronic progressive disease, irreversible organ damage, leading to a very short life expectancy. This is a multifactorial disease, and the eye symptoms are the main ones. It's due to lysosomal storage disease, so there is a deficiency of alpha galactosidase, which causes the organ irreversible damage. Here you may see the cascade of the disease. It is X-linked disease. The gene is quite a complex gene, but there are other ocular manifestations less evident, but certainly cataract, Fabry cataract is a very special one. Then we have ectasias at the conjunctiva and retina, and the GB3 from limbal vessels, and this affects the subepithelial layers, and it may be very helpful. What really helps us is the confocal microscopy 4. This is so the CS4 images. And this is the subepithelial layer. We are particularly interested because this is where the GB3 deposits are located. Let me show you how this changes when GB3s are deposited intracellularly. And this is the confocal microscopy. And here we can already make a differential diagnosis between the GB3 deposits, differentiate between vortex GB3 and amiodarone. So the message, the bring-home message is different ophthalmic manifestations may appear, but there is one which is really indicative, and we should always bear it in mind. There will never be a direct visual damage, but it is certainly a disease marker. So we must be very careful in diagnosing, and we must be able to diagnose it. We should also remember that as eye doctors, with our ability to make a diagnosis, we can change really the life expectancy of our patients. Thank you so much.